الدكتور خالد الخميسي موجود، ودكتور فواز عمران، دكتور خالد بمخرمة. تأكدوا وجودكم الزملاء المشاركين معنا. دكتور فواز.
اصحاب عدن. احمد مكي. فاضي هذا.
السلام عليكم ورحمة الله وبركاته.
كنا المفروض ننسق معاكم في سيون تعملون زيها، ما جاءت الفكرة إلا متأخرة.
ولا خالد بمخرمة مش موجود.
ايش رايك؟
طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على سيد المرسلين وآله وصحبه أجمعين. Welcome all for the third international conference of Arab University for Medical Science. And today we are starting the first day, which is a very rich day with 5 sessions covering important aspects of the medical education. The sessions for today will cover the keynote talks and also the quality and accreditation, which is very important topic in medical education, and also patient safety and education, teaching and learning, very important topic for the medical education also. And we have distinguished speakers, and we have also esteemed moderators. For the first session, for the keynote session, we have Dr. Abdul Hakim Al-Tamimi as moderator, and Dr. Abdul Hakim is beyond any introduction. He is the Dean of the Faculty of Medicine, Aden University. He is a consultant surgeon. We have also Dr. Al-Abd Bamusa, and Dr. Al-Abd is, again, he's figure in Hadramaut and in the healthcare and the health system. He's anesthesia specialist and also internal medicine. He's the former director of the health office in Hadramaut. And also we have Dr. Abdul Fattah Al-Saidi. Dr. Abdul Fattah is again figure in orthopedic. He is orthopedic surgeon, a consultant of orthopedic, and also he's the dean of the
ريكتر. He's a rector of university now.
He's the
هنيه
congratulations for this new position. He was the dean, now the rector of the International Germany University in Aden. And also we have online Dr. Khalid Al-Khamisi, the dean of the Faculty of Medicine of Sana'a University, and Dr. Fawaz Amran, consultant surgeon, and Dr. Khalid Makhrama, also consultant gastroenterology from Dubai. I will give the mic to Dr. Abdul Hakim to introduce the first speaker, Prof. Ali Batarfi.
Good morning, everyone. Really, I'm very happy to introduce the first speaker, that is well-known professor of medical education as well as surgery, Dr. Ali Batarfi, one of the best students from the Faculty of Medicine in Aden University. Then he is graduated in Iraq, and he one of the founders of the Faculty of Medicine at Hadramaut University. Dr. Ali Batarfi has a lot of participation and a lot of workshop regarding the medical education has been already done in many faculties in Yemen as well as in the Arab country and also internationally. Dr. Ali has been a Dean of Faculty of Medicine at Hadramaut University for a long time. And now he is one of the founders of the Faculty of Medicine at the Arab University. Dr. Ali, welcome for the fourth presentation in this conference.
Okay. Bismillah ar-Rahman ar-Rahim. Good morning, everybody. I'm going to talk today about current and future challenges in medical education. Actually, medical education is an ecosystem. When I said an ecosystem, that means it's a system which is affected by the surrounding systems, whether political, economical, social, and the most important is the healthcare delivery system. Healthcare delivery system is inseparable from medical education. And medical education respond to these changes and affected by it. We can see the driving forces affecting the healthcare delivery system, and as a result of this will affect the medical education. Okay. في مشكلة في القلب ترى. اقلب من عندك. انتوا قلتوا اشر لعندكم، الحين اشر لهنا. First of all, medical knowledge. New medical knowledge, new sciences like precision medicine, molecular medicine, bioinformatics, AI, all are new sciences affecting the healthcare delivery system. New technology. ترى العرض مش كويس. New technology affecting the practice of medicine. When I say new technology, as an example, is introducing of robotics and laparoscopic in practice. This makes significant change in the nature and practice of healthcare. Development of information technology, AI, artificial intelligence, introducing it in the healthcare delivery system have a major change in the medical practice. عد السلايد. New healthcare delivery system. أحمد السلايد مش واضحة. Anyhow, the new healthcare delivery system. The health system is not as before restricted to the walls of the hospital. The healthcare delivery system became in the community. And nowadays they are talking about home care and telemedicine. So we have to train our students and trainees in these settings to be familiar with it, not only in the wall of the hospital, but يا جماعة اقلبوا من عندكم، ترى هذا بطيخ. ما اقلب. So as I said, the healthcare delivery system is not restricted to the walls of the hospitals and goes beyond to the community and to nowadays to home care and telemedicine. So we have to train our student about home care and telemedicine, so that when they graduate in the future, they can practice this. And I'm very happy that telemedicine started in Mukalla last month, and I think in this month, September, we'll announce officially. Is Dr. Abdullah Bahayasami here? Abdullah Bahayasami with us? Okay, Abdullah Bahayasami, Dr. Abdullah is the General Director of this establishment. They will open it, I think, in 15th of September officially. They have get all the permission from the Ministry of Health. And they started actually doing telemedicine in Mukalla last month. We are very happy that this type of care delivery system is present now with us, but we have to expose our student to this type of care. Demographic changes. Now the life expectation of people is prolonged, and you have more elderly people in the society. So, and these also related to the chronic diseases. So we have to respond to these demographic changes by giving the chance to our students to be trained in this aspect. ارجع لأنه باقي واحد. Patients become more educated. Nowadays, the patient is having an access to knowledge. Maybe a patient with bronchial asthma, he may know some information better than doctors in that, not that field. But the access to the knowledge and to the disease become easy now. So we have to take in consideration this aspect to prepare our students. When they graduate, they can be able to deal with patients who can discuss them deeply in their disease. Now, I'm going to talk about what are the implications of healthcare delivery system changes on the medical education. First of all, curriculum. Explosion of knowledge. يا أحمد يا أخي ما كان الكلام مقصوص. أعمل لكم حل.
موجود يا دكتور علي، موجود، الكلام واضح.
Okay, I'm going to talk لما يجيبها. Curriculum. Actually, when people talk about curriculum in medical education, sometimes they are keeping changes in curriculum to the extent that they call it curriculitis, like cellulitis and stomatitis, and curriculopathy, curriculoma. That is curriculum pathology. But we have to take care when we deal with curriculum. We have to be careful about adding or deleting some content from the curriculum. Otherwise, we'll get a curriculitis. When you talk about explosion of knowledge, you can see that explosion of knowledge has doubled from 1750 to 190 in 150 years. Every 150 years, there is a double of knowledge. Then it become 50 years. And then reach to every 5 years, up to 2000. But nowadays, the knowledge is doubled every month. So there is an explosion of knowledge. We have to be prepared to deal with this challenge. And what is the challenge actually? The challenge is between the content and the mastery of it. So you have a content which is doubled, and you want to teach it to the extent that student can master this. So this is a big challenge. How can you deal with increase in the content and mastering this content? Overload, see this. But as I said, the curriculum overload and keeping changing in the curriculum may lead to curriculitis. If you look to the evolution of curriculum, it was a course-based curriculum. It reflects what the student knows. And then we talk about competency-based medical education, what the student is able to do. And when we come to the recent trend in curriculum, which is trust-based curriculum, it's about what you trust your trainee to do. If you talk about competency framework, actually, whether in USA, UK, Canada, Saudi Arabia, Egypt, all are overlapping. They are talking about the student should have the competency of to be professional, to be leader, to be health educate, to be communicator, blah, blah. But at the end of the day, they are overlapping. If you look to the competency in UK system, then you go to USA, to Canada, you will find that more or less is the same. People are keeping taking from here and there. But at the end of the day, it's more or less the same. If we talk about pillars of curriculum, in the past, it was 2 pillars, basic science, clinical science, and that's it. And then they become stress on social science. So it is 3 pillars. But nowadays, people are talking about 5 pillars. Basic science, clinical science, social science, research and innovation, and data technology and big data and technology. It became a pillar in designing the curriculum. So when we announced the objective of this conference, and we said one of the objectives of our conference is to spread and to introduce high technology and artificial intelligence in medical school in Yemen, we meant by it to be in touch with these issues, the important issue, and to fulfill the trend to the 5 pillars. So talking about the curriculum, designing curriculum, you have to keep these 5 pillars. Basic, clinical, social, no way. Everybody is doing it. But we have to introduce to them the innovation and research and big data and technology. Integration.
دكتور
Everybody
علي
is talking about integration, but what do you mean by integration? Even schools of BBL, they are talking about integrated basic science with clinical since early clinical stages or early study years. But in the fact, they are not doing integration properly. Still, there is a barrier between basic science and clinical science. So we have to give this challenge attention. Actually, in Hadramaut Medical College, Yukam, there was a good experience, but unfortunately, we couldn't keep it because of a lot of reasons. One of them is the very shortage of staff. يا أحمد. New teaching staff. As you know, the role of the teacher, it could be, a teacher could be provider of information, could be assessor, could be planner, could be role model to the student. But what we want to insist on it is that we have to move from providing information giver to facilitator, to facilitate learning. Because as they said, the function of teaching is to facilitate learning. فناخذها من قصرها ونركز على learning. For this challenge, we have all the leaders of medical schools should take care about this. They have to give more attention to faculty staff development program. عدل يا أخي. Student. Nowadays, a student is different from a student before 20 years or 30 years. They have been adapted to distance learning as a result of COVID-19. There is an over-dramatic growth of population. I remember when medical school in Hadramaut opened, the total number of students was 40. Then they graduated as 32. 32 students. Nowadays, 200. And they graduated about 150. 5 times fold. So there is an overgrowth in the population. So this challenge needs preparing the school to deal with this, either increasing the staff, increasing the budget, increasing the facility, all these things, infrastructure of the college. And this happened all over the world, not only in Yemen. IBE, Interprofessional Education, I'm not going to talk about it in details. Sumaya Husni, after me this today, she was going to talk about this issue. But interprofessional education become a trend to apply team-based model of care and education. For students in medical school, in nursing, in physiotherapy, in pharmacy, etc., all they are learning together. They are learning together the learning context. But why? Learning together to work together in the practice context. This challenge is actually now it's a hot issue in medical education. So when the medical student learned with his colleague in nurse, the barrier between them will disappear. He will feel his assistant in the ward, a nurse or a pharmacy, he was his colleague when they were in the university. So this will improve the relation between them and the communication. And this trend now, we have to keep it, because some people, they think when I said about medical school and health science, no, make it medical school really, it's bigger, prestigious. No. It's a good chance if you have a school which have program of medicine, program of nursery, program of medical lab, good chance to implement your curriculum and your courses which is together, at least university requirement. لغة عربية، ثقافة إسلامية، لغة إنجليزية، اجمعهم مع بعض، ذوب الفوارق. There is a trend also for the students from day one to be exposed to the workplace and to research also. Don't believe in those people who said, oh, well, how can you build a building with 10 flats and without making a strong foundation for it? This is nonsense. From day one, from year one, you can send a student to the workplace, whether a hospital, health center. Don't say that, no, first 2 years I have to finish basic science. Then I will send them to the clinical. This is out of date. New assessment systems. As in the education and in the technology introduce new approaches, also in the assessment. And as you know, all of you, assessment drives learning. Once you have a good assessment, it's the bottleneck of the educational process. Measuring outcome competencies at different levels of student progression, you have to measure their competency. EBS, I'm not going to talk about it because tomorrow I have a lecture about it. But at least We had to create and orient people about entrusted professional activities so that we can orient people to adopt the trust-based education, not only competency-based education. And programmatic assessment, which needs major cultural change. If you want to apply programmatic assessment, you can't do it like this. Dr. Ali will come tomorrow, I want to apply programmatic assessment. No, we have to prepare people for this. We have to create the situation and the culture among the mind of the student, the staff, the institute. For programmatic assessment also, there will be a lecture by Professor Salah Kassab tomorrow in details, but I want to give a hint just. I will give you an analogy of programmatic assessment to understand it. If you are internist medicine, and you say this patient has HB of 9, so you diagnose him as anemia, this is not enough. You have to know other parameters in CBC, corpuscular volume, platelet, batikh. And then you said it's not enough to say he's anemic by HB. I have to do blood film to see whether this is iron deficiency anemia, pernicious anemia, and so on. I have to do bone marrow, etc. So you did for the anemic patient more than one measure, indicator, investigation to get the diagnosis. The same thing in assessment. You shouldn't depend on one measure for the student to analyze his level. For this reason, there is a very good sentence by medical educator. They said, one measure is no measure. One measure is no measure. So if you said patient is anemic with HB is 9, this is not informative. You will not reach to a proper diagnosis. Same thing in assessment. And portfolio also, there will be
Dr.
a
Ali, 5 minutes more.
okay. Portfolio, I will run. Portfolio, tomorrow, Dr. Suzanne will talk about it. Incorporating technology in medical education, AI, 3-dimension simulations, applications. Go on. تحرك يا أحمد. Academic health system. This is important. Actually, nowadays, there is a trend. Some academic institutions will start as academic health center. Then they will improve to incorporate education in it. And then we'll change it into faculty of medicine. So this trend, as Professor Hussam Hamdi said, going to be a norm, not exceptions. For this reason, role of health private sector, we have to get benefit from the private sector. During COVID-19 in يقام Hadramaut University, there was no patient in Bensina hospital, and we want to teach our student. We make an agreement مع البرج، مع حضرموت، مع الريان. At that time كان قبل العرب، وكنا طلبتنا ندربهم في البرايفت هوسبيتال. فلماذا لا نستفيد من البرايفت هوسبيتالز؟ اصحاب سيون ما يكتفوا بالهيئه، عندهم مستشفى بنزيلة، وانا لي تجربه شخصيه في هذا المستشفى، ممتازين، نظيف، كير عالي جدا، يشركوه. عدن، المستشفيات الكبيره في عدن، ما اعرف ان النقيب او ممكن يدخلون البرايفت سيكتور في تعليم الطلاب. فاينانس، الماليه، الوجع الكبير. تمام؟ والله احنا نقول there is a massive public funding cuts، وفي الحقيقه الماليه هي سرقه، يعني في الاخير يسرقوا الفلوس. ما هذا هو. لا حد يقول لي ما فيش موارد وما فيش حاجه، هي في الاخير يعني عمليه سطو على اموال الشعب. Globalization، العولمه. لم يعد العالم قريه صغيره. People are interconnected. Medical professionals are migrating from country to another country. Collaboration between research in the country. Opening branches of medical schools. For example, German schools أو German university تعتبر برانش مثلا لجامعة دولية، وهكذا. لابد أن هي طلبتنا أن يتعاملوا ويشتغلوا في أي مكان. الستاندرد فور انجريدويت، أنا أريد أركز على حاجة واحدة بس في الستاندردز. معانا الدكتورة أنيسة هي يعني الإكسبرت في الأكريديتيشن. نريد أصحاب الأكريديتيشن، يا ريت تسمعونا، يتحولون من التايم بيزد اديوكيشن، وهذا ايضا موجه للدكتور عبد الحكيم في البوست جرادويت، من التايم بيزد الى التراست بيزد. Not enough to say I will train them for 5 years, for 4 years. No, you have to train them to trust based. when they are ready to go let them graduate. مو لأنه كمل 5 ولا 4. This is time based ولا زمانه، لازم نعتمد على trust based. Finally, are we ready to adapt with the fast changes and continuous evolution? Changes are rapid, faster transformation in the world. We have no other option than thinking globally, acting locally. Thank you.
Thank you, Prof. Ali, for this comprehensive talk, and we'll keep the questions till the end of the session. Now we'll move to the Interprofessional Education, IPE. And who is better than Prof. Sumaya Husni to talk about this topic? Prof. Sumaya is, she has, long biography. She is a board member of National Authority of Quality and Insurance and Accreditation in Education in Egypt. She is a professor of histology and cell biology at Faculty of Medicine, Suez Canal University, in which she served as the dean from 2010 to 2014. She has established the Quality Assurance Unit and led as the development of internal quality system that enabled the Suez Canal University to be the first national accredited school in May 2010, and to be re-accredited again in 2015-2021. She got a master's degree in health professions education from the University of Alliance in Chicago, USA in 1987. She has publications in leading medical educational journals, and she is an IMRO WHO consultant in medical education and editor-in-chief in the International Journal of Health Profession Education, and an editor for the Regional Journal of Microscopy and Ultrastructure. She has long experience in quality assurance and accreditation, where she shared as a chair and a member in many institutional and program accreditation review inside and outside Egypt. She has also worked as consultant for higher education quality assurance project, and she is currently the chairperson of the Committee of Reform and Support of the Undergraduate Medical Education in Egypt. Originally, she is also board member of the AMIMR, which is the AMIMR is the Association of Medical Education in the Eastern Mediterranean region. Internationally, Prof. Sumaya is a board member of the International Social Accountability and Accreditation Steering Committee and coordinator of the standard setting group of the ESAC. In her specialty, she has many international publications, and she is member of the International Histology Promotion Committee. Okay. Welcome, Prof. Sumaya, to talk about the interprofessional education.
I'd like to thank Dr. Ali Batarfi, who is Vice President of Arab University and the Dean of the College of Medicine and Health Sciences, and the President of the conference, for inviting me to this prestigious conference. My presentation will be about the interprofessional education. The topics of my presentation will be definitions. Why do we need interprofessional education? What are the motivating factors for implementing interprofessional education? what are the advantages and what are the core competencies of interprofessional education, the implementation formats, content, teaching methods, and assessment and requirements of interprofessional implementation, challenges, and the situation in the Eastern Mediterranean region. To start with, before we talk about the definition of interprofessional education, let us know what is the meaning of the term professional. Professional is a term that include individuals who have the knowledge and the skills to contribute to the physical, mental, and social well-being of the community. So this is the word professional. So what is the definition of interprofessional education? Interprofessional education occurs when two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. Now, this definition is very important. Some professions being together side by side is not meaning interprofessional education. So according to this definition, interaction should be present between the different professions. We have uniprofessional, and uniprofessional, all of us know this, students from one profession learn together. And this, as all of us did before, we learn together with, for example, from the medicine, from the nursing, and whatever. The second is multi-professional, and multi-professional is from two or more professions, students from two or more professions learn side by side or parallel together. The third is interprofessional. This is our topic, and this means, as I said, from two or more professions learn about, with, and from each other. So multi-professional, they are just learning beside each other, but here there is interaction. The highest one is the trans-professional, and this is, of course, the real higher or trans-professional is a real practice where professional boundaries have been crossed or merged. So our topic is about interprofessional education. So why do we need interprofessional education? Because we want to develop interprofessional practice skills to best meet the needs of the patient. So this is our utmost goal is the service of the patients. So we need to develop interprofessional practice. So interprofessional practice is a collaborative practice which occurs when healthcare providers work with people from within their own profession, with people outside their profession, and with patients and their families. So the ultimate goal is the interprofessional practice. So after almost 50 years of inquiry, the World Health Organization and its partners acknowledge that there is a sufficient evidence to indicate that effective interprofessional education enables effective collaborative practice. And the collaborative practice strengthens health systems and improve health outcomes. So this is at the end approved by the WHO. So let us know what are the motivating factors or the driving forces which lead to the thinking about implementing interprofessional education. The first one is changes in concept all over the world. What are these concepts? The concepts change now from physician-centered practice to patient-centered practice, from practitioner autonomy to team collaboration, from focus on illness and cure to focus on health promotion, from passive patient role to involving the patients and family in the decision regarding the patient. The second motivating factor is the aging population. Now, as the global population ages now, the care of elderly people becomes more important. as does the concomitant need for treatment and management of long-term conditions such as arthritis, diabetes, and hypertension, and other chronic conditions. So these demographic changes require a shift in focus from acute service delivery to chronic care model that require the interaction between the healthcare team. For example, if a patient has a stroke, he needs a paramedic, he needs a physician, he needs nurse, he needs a psychologist, he needs physiotherapist, and so on. So the team is very important in these chronic conditions. Another driving force is the advancement in technology. So the advancement in technology now needs a team with the physician to run the machine, to be a technologist in information technologist, to do the analysis and the statistics and all these things. Also the specialization. You know now that there is increased tendency for subspecialization of the physician. So that's need that many subspecialty as a team will need the help of the paramedic team also to take care of the patients. Another thing is the patient safety and the quality of care. When I have the patient to be seen from different points of view from the different professions, this will help in seeking the quality of the care for the patients, and also the safety of the patient. This will ensure also the safety of the patients. Workforce pressure. Now there is overloaded physicians. So if I give some of the roles of the physician to other profession, this will lead to better care. For example, the midwives and the health worker can do some of the physician role, which will help ameliorating this overload on the physicians. So this is most of the driving forces. So the research talks about the advantage of interprofessional education and interprofessional practice. There is ample references about that. First, they found that the interprofessional education improved the communication between the different professions. Second, they found that it enhanced the learning process. When all the team learn together, they benefit from the brainstorming between each other. It improves the contribution of each profession. Each profession want to show others that they have a contribution. So this it will improve the contribution of each profession. It reduces competition very much, because this is a teamwork and collaboration, so it will reduce the competition between the team. Better handling of conflicts. If there is conflicts, they use it to learn with each other when they have this during interprofessional education. So when they come to practice, this will reduce the conflicts and make it very easy for them to handle. Better problem solving and creativity, and the same because they used to work together and solve the problems together. Improve clinical outcomes and quality of care, as we said before, that they work together, all of them look for the quality of care and the outcomes of the patient at the end. Better safety and cost effectiveness. Of course, if I look to the patient from different profession, this will give me better safety for the patient, and of course the cost effectiveness, because I may use other profession to have some roles of the physician, which will cost less. Strengthen professional identity and satisfaction. They found that this interprofessional education from the beginning in the years of study will help each profession to feel that they have an important role to do, and this will improve the job satisfaction for each profession. Now there are many or several يعني competency framework developed for the interprofessional education. Some examples are, we have the United Kingdom Interprofessional Capability Framework, we have a Canadian Interprofessional Collaboration, we have Australian Interprofessional Capability Framework, we have Japan, the Japan Association of Interprofessional Education also put a framework, and we have USA Core Competences for Interprofessional Collaborative Practice, Interprofessional Education Collaborative, and this is started in 2011, and then they updated it in 2023. That's why I will stress on this one, and will talk about this frame of competences. This frame of competences produced a core competences report of the expert panel, who are from American Association of College of Nursing, American Association of Colleges of Osteopathic Medicine, American Association of Colleges of Pharmacy, American Dental Education Association, Association of American Medical Colleges, and lastly, Association of Schools of Public Health. All experts from all these associations shared in the development of these core competences of interprofessional education and the practice. So let us see what is the domains of these competences. The first domain is values and ethics of interprofessional practice. The second is roles and responsibilities. The third is interprofessional communication. And the fourth is teams and teamwork. We'll talk about each one in brief, because each domain has a competency and sub-competencies or key competencies. A lot of them, I can't talk about them together all over, so I will summarize each one. So the first domain, as I said, values and ethics for interprofessional practice. Work, the student should work, or the doctor should work, or the team should work with individuals of other professions to maintain a climate of mutual respect and shared values. Under this is the first competency. Under this competency, there are 10 key competencies. I will summarize them in this. The patient is at the center. So this is the first thing required here. The patient should be at the center of the practice. There should be respect to the patient dignity and privacy and confidentiality, because all of this related to ethics. The second is each one in the team should demonstrate ethical conduct with patients, families, and the team. Third, should respect values, roles, and expertise of other professions in the team. Each one should respect the values, roles, and expertise of other professions in the team, and this is very important point. So this is, I summarized the 10 key competencies in these items. Let us see the second domain, which is the roles and responsibility. Use knowledge of one's, this is the competency statement, use knowledge of one's own role and those of other professions appropriately, assess and address the healthcare need of the patient and population served. So this is the role of each one. So there are 9 key competencies under this competency. The first is communicate roles and responsibility to patients and families. So the patient and families should understand the role of each one in the team. This is something very important. Second, to provide care that is safe, timely, efficient, effective, and equitable. Then to clarify each member's responsibility in executing tasks. So inside the team, each one should know his or her responsibility in doing any task. So this is the main summary of the roles and the responsibility. The third domain of competency is the interprofessional communication. Communicate with patients, families, communities, and other health professionals in a responsive and responsible manner that support team approach to the maintenance of health and the treatment of the disease. This is a very important also domain or competency, and under this competency, there are 8 key competencies. First, use clear information and avoid discipline-specific terminology. So when we are in the team together, as a doctor, for example, I don't have to use some specific terminology which is not known or not known by the nurses or by the pharmacist or by the dentist. So I have to use clear information and avoid discipline-specific terminology. Listen and encourage ideas and opinions of other team members. I should also, if I want to talk, I also should listen to other ideas and respect them and encourage them to talk. Give clear feedback and respond respectively to others, and use respectable language in any interprofessional conflict. If a conflict happens, we should use respectful words when we try to solve these conflicts, and give feedback and receive feedback from others. So these are the 3, and then this is the 4th domain, which is the teams and the teamwork. Here, you should apply relationship building values and principles of team dynamics to perform effectively in different team roles, to plan and deliver patient population-centered care that is safe, timely, efficient, effective, and equitable. Here, there are 11 key competencies here. The most important is that the team should develop consensus on the ethical principles of patient care and teamwork. All of us as a team should have common principles to use with the patient, ethical principles. Engage others in patient problem solving, integrate their knowledge and experience. For example, if I am a doctor, I don't have to take my opinion only and avoid others. I have to integrate their knowledge and experience also in the problem solving of the patients. Then you have to manage disagreement about values, roles, goals, and actions. If there is disagreement among us, we should have to manage this, to have exact roles, goals, and action. So each of us should follow so that the team can have achievements. Okay, now we finished with the competencies developed. And this competencies is very important for any school which will implement interprofessional education. They should take these competencies and key competencies and derive their ILO's intended learning outcomes from these key competencies. So when there are many formats to implement interprofessional education. First, I can do it in interprofessional day only, one day. I can do a workshop or can do interprofessional education seminar. Others can make one module or more than one module in the whole curriculum. Others can make it in like interprofessional education clinical experience. They can do an experience for the student in the field. Or we can make it like e-learning in parallel with other courses. We can also incorporate throughout the entire curriculum. Some schools integrate and incorporate the interprofessional education throughout the curriculum in each year in a definite time. How I can choose any one of these? This depends on the student, my student number, the timetable of my student, the whole size, because I will do for example, interprofessional activity. So I have to bring the people from different professions. So do I have a hall to accommodate all these people? Or if I have a clinical placement, do I have the placement for accommodating all these students? And then the number of facilitators. I should have facilitator train the facilitator to conduct the interprofessional education. So I have to have a good number of facilitators to run these activities. What is the content of the interprofessional education? The content should be matched with the ILO's intended learning outcomes, as I said before, derived from the competencies. So I have competencies, and I have to derive the ILO's from them. Then I have to select topics from relating to these intended learning outcomes, and this topic should be best covered with an interprofessional approach. So the topics I will select should be matching all the profession. Now let us see some examples of the topics, roles and responsibilities of various health professionals. This can be one of the sessions. Another one, principles and development of teamwork. Healthcare system, health promotion, healthcare ethics, evidence-based practice, interprofessional practicum, management of diabetes in pregnancy, childhood obesity, asthma, drug abuse, etc. So as you see here, the topics is not related to any profession in specific. They are the general topics according to the competences and the ILOs. And if you put something like some scientific topics like diabetes and so on, this should be very generic so that all the profession can tackle it. Diabetes in pregnancy, this can be discussed by the doctor, by the nurses, by the pharmacist, and so on. Childhood obesity, asthma, drug abuse. So it is very generic topic to be discussed as a content of the interprofessional education. So what are the teaching methods and learning activities that can be used in the interprofessional education? You can give a lecture with discussion. This is very important, the discussion, because when you give a lecture, for example, for the roles and responsibility of the team, so you can make it at a lecture, and then you have to discuss with the attendants to hear from each one. This will give the interaction needed for the interprofessional education. Second, you can make a small group discussion or case-based discussion, and also discuss any topic we have talked about. Can do it in class discussion and out of class project. So they can discuss a topic and then go out the class to perform or to conduct a project. Another teaching method is the team report of in-class discussion. After the student discuss a topic inside their classes, they can go out and write a report as a team and then present it to the group. Assignments relevant to recording or videos. You can record a video or show them a video or give them a reading and then give them assignment according to what they have. Community project. You can ask them to do a project related to these topics, and all of them will share in this project. Another thing is shadowing other professions. One profession can shadow other profession, or they can shadow even the community worker or the patient. If they shadow the patient, they can know how the consumer point of view. So they can shadow any other profession or patients or community workers. Then you can give them a healthcare team challenge. For example, you can ask your students to give them a challenge like a low immunization rate in a specific area covered by a primary health care, and then ask them to have a specific approach for solving this problem and give a recommendation as a team. And in this case, they will also collaborate with the team in the healthcare in the primary health care centers. Regarding the assessment, of course, any assessment should be based on the intended learning outcomes and the competencies. And then it should cover all the learning domains, the knowledge, the skills, and the attitude. And then the types, as we used to know, we have the formative and summative assessment. So the formative assessment is done through 360-degree evaluation from all sides for the team, and this will be followed by constructive and timely feedback for the students. Another type is for the formative is called the team objective structured clinical examination. It is like the OSCE. I'm sure all of you know the OSCE, but this is for the whole team. So the whole team is going to the different station, and this is considered from the formative and not the summative. So what about the summative? The only way used for the summative assessment till now is the portfolio. So to implement interprofessional education, you need institutional support and committed leadership. This is very important. Second, you need financial, physical, material, and human resources. We need facilitators, and you need some financial, you need physical to have a space for the sessions. We need some financial support to give the facilitator some incentives and so on. Multi-professional committees for planning and organization. When you plan for the interprofessional education, you have to involve different professions in the committee in the planning committee. You don't have as a doctor to sit alone and put the plan. You have to have one from every profession to give their opinion about the plan. Then awareness and capacity building for faculty members. You have to train your faculty members to be able to do these activities. Selecting common IPE competencies and key competencies. Decide about the competencies you will use and the key competencies you will use, and then derive or write your intended learning outcomes and selecting the content. And of course, all of this done by the committee, which include different professions. Then decide about the used format, which format you will use, what are the learning activities, what are the teaching methods, and this of course depend upon I said before, the number of students and the spaces and everything you have. Then prepare the assessment plan and methods and put a plan of the follow-up and monitoring of the process. So always for any thing, there is some challenges. So what are the interprofessional education challenges? The first challenge is the curriculum structure and the content. Because you are dealing with different professions, every profession has their own curriculum structure and content. So to agree on a common curriculum and the content, this is a big challenge. The second is the timetable. Timetable is also difficult because every profession has its timetable, and you want to have and to find a specific time for all the profession to sit together to take the interprofessional session. So this also is a big challenge. Student number. If you have, for example, a large student number from one profession and a low or a small number from another profession, this is a challenge because there will be no balance in the activity. Lack of central planning. Planning and administrative support. There should be central planning, as we said, and administrative support. If you start this, the activities before planning, and this planning central, as I said before, with involving of all the profession, this is a big challenge also. Lack of resources, including trained staff. The trained staff, as we said before, is very important. So this also a challenge to find a trained staff for these activities. Stereotyping and professional domination. Always the other professions think that the doctors are who give the decision. They also see that they are dominant, and they always they have the move for any activity or anything during the session. So this will create a gap between the different professions. So this is a big challenge to allow everyone to know that he is one of the team and he is not dominating or she is not dominating. differences in learning needs, knowledge, and the approaches to practice. So every profession has a specific approach to practice, and they have different learning needs and knowledge. So this all will create some challenges that should be solved during sitting together and planning for the activity. The last one in the challenge is the difficulty in assessment. As you see, when I show you the types of assessment, it is only for the portfolio. So all the people think that there is no valid and reliable assessment method for the interprofessional education, and specifically for the teamwork and the collaboration between the team. So this is a very challenging thing. Additionally, some certifying bodies need their student to be examined by the same profession. And this also creates a big challenge, because the student now take the activity together as an interprofessional team, and then when they come to assess, they assessed by different persons. So this is also a big challenge. I just want to tell you about the interprofessional networks on the global level. We have interprofessional global, and under this interprofessional global, we have African, Arab network, Australian, Canadian, German, Indian, Nordic, South and Central American, United Kingdom, United States of America, and there are 2 new emerging networks, Asia Pacific and Dutch-speaking countries. In the Eastern Mediterranean region, we have now a very good network, the Arab network for interprofessional collaboration, and this is run by Qatar, and this is a very good, network, and we all should try to share in this to develop it. I just want to tell you about the publication in the Eastern Mediterranean region in the field of interprofessional education. We have publication from all these countries, and when you read in this publication, you will find that all of them shared in the activities, what the activities they do for the interprofessional education. They have field training assignment, they have field projects, workshops, seminars, small group discussion, and interactive lectures. So these are the activities reported in the publication of the countries of the Eastern Mediterranean region. Regarding the many challenges for the Arab countries, they are the lack of structured curriculum. As I said before, there is no structured curriculum, so each one do whatever he or she is like. And then there is difficult curriculum alignment with other. They feel this is a major challenge for them. And inadequate formal interprofessional education, there is no formality. So if it is not formal, it will not be taken seriously. Lack of trained facilitators, they don't have trained facilitators. There is lack of a structured way of student assessment or difficulty in assessing the multiple profession. And last one, there is no assessment of the short-term or long-term student learning outcomes. This is our AMI guideline for interprofessional learning in practice-based setting, and I would like all of you to read this, because it has everything about interprofessional education, and it is recently published in 2024 this year, and I hope you will like it, inshallah. This is my references, and thank you.
Thank you to Professor Sumaya Hosni from Egypt. And the next is Professor Muhyiddin Maydoub. Yes, Muhyiddin Maydoub, in United Arab Emirates. He's a professor. He's a professor of and chair Department of Medical Education College and Medicine and Health Sciences, the United Arab Emirates University. He have been working in field of healthcare and medical education since early 1980s, 80s in Sudan, Saudi Arabia. He have a wide and diverse experience in both hospital and medical education administration. He have undertaken consultancy project on behalf of WHO and other prestigious organizations in Syria, South Africa, Kenya, Brazil, USA, and elsewhere. He published excess of 100 publications, routinely participate as a speaker and moderator of international symposiums, and routinely oversee courses, seminars, and workshops in the field of medical education. His specialist is he's a medical dermatologist, medical education, health promotion, medical statistics, and epidemiology and health system researches. Welcome, Dr. Muhyiddin.
طيب، بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. أول نشكر جامعة العرب لإتاحة هذه الفرصة للتحدث في هذا المؤتمر الهام، والذي عرفت أنه يجمع أكثر من 900 مشارك، ونتمنى أن تكون هذه المشاركة مفيدة للجميع. Today I'm going to talk about a new approach to curriculum design, which I call it patient and population-centered medical education. And this is, we hope that this is going beyond the current competency-based medical education framework and addressable professional activities. So this is now the latest. Muhyiddin Maghzoub, Professor of Medical Education and the Chair of Department of Medical Education at the College of Medicine, United Arab Emirates University. Okay, so this is my co-authors from different parts of the world, including Professor Hank Schmidt and also Professor John Orsini from USA, and also other colleagues from Sharjah University, and also from our own department at the Medical Education Department. In this presentation, I hope that I will cover the needs and justifications for this new approach, and then the methods we have used to develop this framework, for this new framework, which includes the literature review, the study, and then interviews and meetings. And then I'm going to present the framework, and then I'll have a conclusion. So the needs and justification for developing this new framework in medical education, which we call patient and population-centered curriculum. This is due to the past experience with medical education and the challenges and drawbacks of previous framework, and then the challenges of the current competency-based medical education. And then also another reason is research or advancement of research in clinical reasoning, and also research on assessment, research on health services, and the assessment directions and technological advances. So all this led to the development of this new framework, and I'm going to touch base over each point briefly. The needs and justifications is the lesson learned from the history of medical education. As you know, that the history of medical education started, the current medical education approaches started in 1910 but is what we call Flexner model. Flexner model is a psychologist and medical educator in the United States who criticized the present framework at that time, which is the apprenticeship model. And the apprenticeship model actually, fortunately, developed in this part of the world, where students really peer with the supervisor, and after they have certain competencies and ready for practice, then they will be certified as physicians. And this is, and then in 1910, Professor Flexner said this is not really an academic approach, and it's not scientific. Medicine is academic discipline, and it is a science. Students really need strong base and foundation on basic medical sciences, then they move to the clinical sciences. And this is really what now is prevailing the whole world, which is a traditional model of medical education that starts with foundation or basic sciences, and then move to the periclinical, clinical, and then the clinical at the end or the last 2 years. So students really, they will not be exposed to patients unless at the end of their education. And actually what happened after that, and then after that came, this really, the Flexner model continues for a very long time, for decades, until early 1970s and late 60s. In McMaster, a new model of medical education has conquered or started conquer the world, which is the problem-based model, as well as the community-based education model. In this, also, they look to the drawbacks of the Flexner model, which is teacher-centered, and then focus on factual knowledge. It is a discipline-based, and some information overload, and then the late exposure to patients. So actually the model of PBL just tackle these disadvantages and overcome them by introducing student-centered approaches, which is a problem-based learning, and it's really based on learning theories and with early clinical exposure, which is like the apprenticeship model, and then the integration of the curriculum. And then the students find it really more enjoyable and satisfying, and it encourages greater understanding of students, collaboration, and so on. So and it's also develop lifelong learning skills. So this really tackles the immediate problems of the past model, which is the Flexner model, and then after that, the competency-based model came, and they criticized the PBL community-based medical education model by being process-oriented and not really related to outcomes. So this really is the main criticism, and then it's focus on daily physicians' professional activities, which may involve more than one competency. This is also so the main advantage really of the competency-based medical, which is the current framework, is the focus on outcomes. That really medical education look at the competencies at the end of the program, and then they design the program accordingly to graduate competent doctor who is ready for practice and fit for purpose. So this is also a very big advantage, but at the same time really forgot the process and model, and also the focus on teaching and learning, the focus on assessment is lost, and also the curriculum design, but it's only focused on outcomes. So from the experience in medical education, we can observe that really each model is focused on only on the disadvantages of the previous model, but there is no really a global look, and they forgot, unfortunately, to accompany the advantages of the previous model. So this is one reason really for us to think of this new model, which can take care of all the advantages of the previous model, even the apprenticeship model. Also, they have very big advantages of great exposure to patients, and also the students stay all the time from the beginning until end with patients, and more interactions, more collaboration. It has advantages, but also we should not forget the flexible model, which also has advantages of having its scientific foundation. Also, the PBL has advantages. So all these models really have advantages, but unfortunately also they have disadvantages. So in our framework, that really we combined all these advantages and also tried as much as possible to avoid the disadvantages of all these models, as we can see later. Okay, so the other patient-centered approach to medical, if we just can cover the other reasons for going into patient and population-centered approach is the clinical reasoning approach. That is, the clinical reasoning is the reaching diagnosis and appropriate management, data gathering from history, physical exam, and so on. So the clinical reasoning research is telling us even a competent doctor can make mistakes. And the medical errors, it might reach 40% even with competent doctors. This is really from research on clinical reasoning. And this mistake is mainly due to biases that introduced by a factor apart from knowledge and competencies. And they group these factors into factors related to doctor, for example, the pressure or interruption or pressure of time and so on, and also the working conditions, factors related to patients, which is really given wrong history or not unbiased history. Also difficult patients and arrogant patients, also they can affect diagnosis. And then also other biases related to the health system, for example, like insurance, their overload, and the focus on profits and of the current insurance system. These are all leading to great medical errors that cause even by competent doctors. So that this is also a very big or important reason to move one step further. Also, doctors use non-analytical systems. This is the analytical approach to clinical reasoning. So that even if you study or educate our students on the analytical system, starting from taking about history, doing proper physical examination, differential diagnosis, reaching a diagnosis, but really when expert, the doctors face with patients, they don't really go to systematically. So they use what we call system one errors. That is, they have pattern recognition and immediate patient when he talk, even in the first minute, doctor really try to jump to diagnose and just try to match what the patients mention with the patterns of diseases in their mind through their experiences. And so this is really system one system, which is really not used only in medicine, but in all areas that require decision making. So this is also another reason. So reasoning mistakes are often being attributed to cognitive biases produced by the application of heuristics, that is, the shortcuts reasonings. Physician competencies and cognitive achievements are not enough really to prevent medical errors. The needs and justification research into clinical reason, a patient-centered approach to medical education should provide students with far more opportunities to practice clinical reasoning through linear simulation. So this means that really, if we want to do a good job, that we should expose our students to a variety of cases and in different situations so that they develop their own pattern recognition and use system one even when they're medical students. Promote interprofessional consulting and promote reflections and reflective practice. So these are all important strategies that we have to use to increase the clinical reasoning of our students, strengthen empathy, communication, interpersonal leadership competencies, and so on. So the other needs of justification, which is the already how most health system move to patient center and person context healthcare. So that is our colleagues in the health system, they already moved to patient center care. And now even sometimes they exaggerate this. Now hospital become like 5-star hotels. For example, in UAE here, when you go as a patient, just as if you are entering a hotel, that you find even coffee, tea, just to attract patients. So this is really important because they want to have maximum satisfaction of patients. This is really important. So if our colleagues in health services, they move, why not medical education move into that direction? So implication to medical education that joint outcomes of medical practice and medical education, focusing on patients, and then trainees should speak with patients and their families more than they do now, and listen to their concerns and to incorporate their wishes and preferences in the management of the patient's problem. So these are all important strategies that we have to accompany on our new model. Other needs and justification, research into assessment, now also assessment moved to program assessment, which look to the whole system, not really like what we do before, just focusing on reliability and validity. But we have to look at assessment as a program and then really make the outcome as always as an end point of our graduates. And then we have a portfolio to see the development into competencies even from year 1 until year 6. Research into empowering students. This is also students that their role should not really be only as knowledge receivers or clinical skills training, but also they should be empowered to have a say in the curriculum, also as health services providers. And in, for example, in the United States, they have privileges for the students that they can really do and perform, and even they can enter in the medical records. Moving from interdisciplinary to interprofessionality. So this means that also doctors alone cannot do a good job. You need also the colleagues in nursing and in other paramedics, which is really as a team we should work. Research into artificial intelligence and its impact on the future of medical education. So this is also now knowledge really is a tip of the mobile, and it really has a great implication into medical education. So now students really they can learn faster, they can find any information quicker, and also not like our days where we depend on research and textbooks and we have to consult them and so on. But now really knowledge is available everywhere in the mobile, and even in very poor countries, they have very good connections. For example, like what now we are doing, with really very good connection in Yemen, and also even in areas with conflicts. So there is some kind of communication. Okay, so aim of the studies that we have done some studies and to identify the frameworks. And this is really, we are using the SIP model, which is the contact, input, processes, and products. So really, for example, if we want to develop our new framework, really what the inputs at the level of medical education that we need. And this really should be guided by the context and what are the processes and what are the products. So we should not only depend on the product like competency-based education or processes like problem-based learning model or the input like before. So this is really, if we want to do a good job, we should take care of all these 4 levels in our approach. So we have done a lot of methods to collect data to validate the framework. We have done a literature review with scope reviews to see what is going on in medical education. We have done a Delphi conference methods with 32 international medical educators. And then on the second round, we have a response from 20 medical educators. And also we have done some interviews and focus group discussions. And then we have done thematic analysis for all qualitative responses, which we have 119 propositions summarized into 6 themes. So the themes, the major findings that we have identified 6 themes. So that in our approach, that is comprehensive patient-centered approach, that is analyze how curriculum extensively prioritize patient perspectives and needs, detail strategies for patient and community involvement learning, and then some 2 ethical and moral framework in medicine, which is also on other framework as well. That's the cultural sensitivity and diversity. So this we have to respect patient cultural background and diverse in countries, for example, like UAE, which have more than 100 nationalities. So these are all important factors has to be considered. And then also innovative educational techniques. This is very important to have cutting-edge teaching methods such as simulation-based learning, team-based learning, digital platforms, and since their impact on learning. So this is concerning the process. Community engagement, social accountability is really very important because in medical education, we are accountable to the society who pay the money for government and also the families who pay money, for example, in private medical schools. Also, we have to respect and respond to the need of families and the need of the country who finance medical education. And then the 6th theme is interdisciplinarity and collaborative learning. Here we mean not only on the disciplines within the health field, but also disciplines outside the field, also affecting health. For example, like politics, if you look to COVID-19, it's not really only affecting health, but also affecting politicians as well. And even government took it as a priority. It's not really no longer only the responsibility of Ministry of Health, for example, like the COVID. It become an international pandemic, local pandemic, and others. So this is very important to consider the sectors outside the field. For example, like education, schools, agriculture, environment. These are all affecting health. So with this really broader aspect, so this is the level of agreement of experts with the model, so that you can see most of them strongly agree with all what we have put. And then present the framework. The framework really start with the para factors like the context, and the culture, which is really outside the control of the medical education, but is very important and it influences medical education. And then the extrinsic factors, like in the health system, these are also important. And then the context within the medical school, like institutional culture. So these factors, which, and then we have inputs. This is really very important, which affects medical education. There is the mission, the vision, the values of the institution, the human and physical resources, the stakeholders, level of stakeholders involvement and mission criteria, because sometimes really we have to do a very good job on selecting the appropriate students, policies and regulations, and then others contextual factors. The processes which really put those inputs into action, like well-designed curriculum. So we need really a strong department of medical education, very important, or at least educators who are knowledgeable about education and medical education. Then we have to promote student-centered learning, like flipped classrooms, no more lectures, because lectures really are the worst methods of teaching, but they're cheap and people really used to it. But I think students, if you allow them or if you make it optional, very few students attend lectures, and they do more jobs by reading and depending on themselves, and also in using other important methods like team-based learning and flipped classrooms are really found to be much better than lectures, and then as others contextual processes, which is very important. And then after the processes, then we should have the impact. This is really what we want of medical education. At the end, we want satisfied patients and population. We want and what the patients want from doctors. We want accurate diagnosis and appropriate management of patients. And then this is really definitely will be reflected in the institutional accreditation and ranking. And this is outcomes, which is really competent physicians. Important that we have to graduate doctors with competencies, but we should always remember that a competent doctor is not really enough. We need more than that. Readiness for practice, who are really ready for practice. And then we need really to promote the partnership with all stakeholders. And then the faculty enhancement, faculty development programs, very important, then institutional recognition. So this is definitely, all these processes will lead to the impact we want. So this is really a new model of medical, which we are promoting now, and we call it patient and population-centered medical education. And we hope that it will have influence on medical education internationally and definitely regionally. And really, we're ready to collaborate further on this with the Arab University and other universities in the region, because really we think this model really came from here. All other models came from. This is going to be published in Medical Teacher in November issue. It's already accepted, and so this is really what we have now for patient and population center curriculum, and then we are ready really for any questions. Thank you very much, Dr. Ali Batarfi, our friend for a very long time, and thanks for all colleagues in Yemen. And we hope really we will have more opportunities for collaboration. Thank you very much.
Thank you for Professor Mahiddin. Now we will shift to Prof. Salahuddin Al-Kassab, Salahuddin Kassab. Really, I'm feeling jealousy because he had a great CV. Prof. Salahuddin from Egypt. His Prof. Kassab is Professor of Physiology and Medical Education and Associate Dean Academic at the College of Medicine, Gulf Medicine University. He is also Professor of Physiology at the Faculty of Medicine, Suez Canal University. He has conducted several workshops on the different area of medical education in Bahrain, Saudi Arabia, Egypt, Yemen, United Arab Emirates, Qatar, Tunisia, and Jordan. So he have a great CV. So, Prof. Salah, all we are ready to listening to you. You can start.
بسم الله الرحمن الرحيم. أولا بشكر الأستاذ الدكتور علي بطرفي واللجنة المنظمة للمؤتمر لدعوتي في هذا المؤتمر. topic اليوم على ال student engagement in medical education. It's a very important topic. Yet it is not really well covered in the literature. فيعني
طبعا talk about student engagement in medical education.
بسم الله الرحمن الرحيم. أولا بشكر الأستاذ الدكتور علي بطرفي واللجنة المنظمة للمؤتمر لدعوتي في هذا المؤتمر. والتوبيك اليوم على ال student engagement in medical education. It's a very important topic. Yet it is not really well covered in the literature. فيعني my task in the coming 25 minutes or so that I'm gonna give you an idea about the construct and how it is measured, what is it, and how to stimulate student engagement in medical education. When we think about student engagement in general, we are looking for a class like this, probably, where the interaction is very high with the students. They are extremely happy. And maybe something like that is the opposite of the student engagement. But actually what I'm going to present to you is that student engagement is much more than that. So I'm going to present a broader view of student engagement and something that is probably quite recently emerging in the literature. So this is a presentation outline. What is student engagement? Why is it important? The framework for student engagement in medical education. What are the theories underlying medical student engagement and the dimensions? And another dimension, which actually it's one of the issues that is just emerging in the medical education literature, which is student engagement in as partners in education. And then drivers and inhibitors of student engagement. Probably the focus will be more on the drivers and the outcomes. So why is student engagement important? First, it correlates with academic achievement. So students who are more engaged in their learning, they achieve more in their scores of the whether across the academic year or across the medical school. So their GPA correlates strongly with their degree of engagement. Engagement is also a negative predictor of student burnout and the student dropout from the medical school. And not only the impact is on the students, but actually the teachers. When the students are engaged in a class, the teachers will become more motivated and they become more enthusiastic to their teaching. Because of the previous issues, the student engagement is now becoming a measure of institutional quality and excellence. For example, the Aspire criteria that is mainly organized by the AMI is actually awarding an institutional excellence based on 5 criteria. One of these criteria is the student engagement in medical education. Also, World Federation for Medical Education, they included the student engagement as one of the indicators of quality. And also the QAA authority, which the British Quality Assurance Authority, they are having student engagement as one important measure of the institutional excellence. So because of that, actually the literature is increasingly addressing the concept of student engagement. However, in general education maybe started earlier than medical education, and only from 2002 started the literature to be published about student engagement in medical education. And you can see that from this graph that the highest percentage is only coming in the previous 4 or 5 years. We started this venture of looking at this construct by a scoping review that was published in Medical Education Journal. That was the starting point actually to examine the construct. Of course, I personally had an interest on the topic because I was also supervising one of my master students in medical education, and it was around that same topic. And then that was followed by an Emmy guide that we published last year in medical teacher, and it was addressing the student engagement in health profession education. So we delved strongly into the construct, and surprisingly, it was not really very well addressed. So we identified a lot of gaps around the topic, and also what we did is that we developed a framework around the student engagement that I'm going to address with you. Now, the main question that anyone will think about, what do we mean by student engagement? And many issues, I think it's still a very fuzzy construct, but when we talk about student engagement, maybe I think looking at this word cloud will give us some idea about what it means. So the governance, the belongingness, the working with peers, active learning, the motivation of learning, and so on. So engagement is a very broad construct. And we started to define the construct in our Emmy guide. And this is the main definition that we used: student investment of time and energy in academic and non-academic experiences, including learning, teaching, research, governance, and community activities. And there are 5 dimensions that we included in our framework: the cognitive, the affective, the behavioral, agentic, and sociocultural dimensions. Now, going back to the theory, there are 3 main theoretical perspectives that could explain the construct of student engagement. The first one is the psychological perspective, which is the most commonly used in the literature. The second is the behavioral perspective, and the third is the sociocultural perspective. So I'm going to touch very briefly on each one of these because of the time limit. Some of the models that emerged from the psychological model, and this is probably was one of the first models that emerged, is the participation identification model, where actually when the students are they participate, meaning that they are behaviorally engaged in the class or in extracurricular activities or in decision making, their performance increases. And so their academic achievement is increased. And as a result of that, they start to link with the medical school, and they what we call it identification. So their sense of belonging and their valuing of what they are doing in the education increases, and this is the emotional engagement. And this emotional engagement will lead them to more participation and so on. That participation identification model is still a very active model, even though it emerged at the late 80s, but still cited in the literature and several papers, especially in actually higher education rather than in medical education. One of the most probably commonly used theories that address the student engagement is one of the motivational theories, and which is the self-determination theory. And simply, it dictates that students will become more motivated for learning if they feel that sense of competence, or they become more independent in their learning, or they feel the sense of the community and the sense of relatedness. And because of that, they become more motivated. And then the engagement came in as a consequence of the motivation of the students because of these basic psychological needs. That's how they are calling it in the self-determination theory. So these these 3 parameters will increase the motivation, which increases the engagement of students. The third theory, which is very common in the gaming, in software engineering, where actually it's called the flow theory. If you want the users to get engaged with the game or something, then you design the game, and they are very good in that because they design the game to engage the users in these games in what we call it a state of flow. What is the state of flow? They become intrinsically enjoyed when they are doing it. They become fully concentrated. And we know that, you know, all of us remember what our kids, you know, when they are using the games, or even some of us may be doing the same, the time flies. Loss of self-consciousness, and you know, 3-4 hours may pass, and then someone will think that I have just started, and then they will have the intention to return back to the same game. So this is like a state of addiction where actually they get enjoyed. Now the flow theory, from its use in gaming, it became imported into the education, and some of the use of games in education or gamification in education now are based actually on the flow theory, where using games that are designed to hopefully make the students in a state of flow. Now, the second perspective of student engagement is behavioral, and this is not really very well used, even though actually it is based on one of the most common surveys that are used in the United States, which is the National Student Engagement Survey, which is used for comparing the performance of different medical school or different actually institutions. And then it doesn't look only at the student behavior, but also look at the institutions, what the institutions do to enhance the student engagement. And even though it looks at the engagement at a broader perspective, but the drawback of this behavioral perspective is that it makes the student engagement construct more fuzzy, and then rather than being focused on the internal psychological state of the user, now the institutions became part of it, and then, you know, when research needs to be done, it becomes very difficult to delineate which one is which. The third perspective is socio-cultural, which looks at engagement as a social and cultural sort of activity. And it is based on the common community of practice theory by Wenger, where when people, they have shared domain of interest, shared vision, shared goals, and they are practicing something, then they will get involved in it. And again, this is becoming a more emerging in one of the aspects of engagement that I will talk about very soon. This is the framework that we published in our ME guide, and we developed this framework trying to delineate the very wide framework of this construct, because it has not been really well defined in the medical education, or actually in health professionals education literature. So we looked at student engagement with 5 dimensions: behavioral, emotional, cognitive, agentic, and sociocultural. And we have what we call the spheres of engagement, where students can be engaged in their learning, but also they can be engaged as partners. And this is a very novel part of the framework that has not been addressed in other literature. Now, we looked also at the drivers of engagement, either from the institutions, from the students, or the relationships between the students and the institutions. And also there are mediators of engagement like motivation, self-efficacy, reflectivity, belonging, and then the outcomes at the end as short-term and long-term. This is a very broad framework that was mainly designed based on the existing literature, but we tried to combine the concepts together and address also the student engagement as partners, because that was absolutely missing from the literature. And also in education, the difference between considering the student as a consumer of education or actual partner in the education process which is as I said, it's a novel approach. Now, when we simply look at what we mean by cognitive engagement means that students, they invest a lot of mental activities in their learning, like using higher order learning, getting immersed in what they study, they become fully concentrated, they value what they are doing. And the behavioral is simple but something that is observable, like doing more effort in learning, or being persistent, failing and then trying and failing again and trying until the student will succeed. Actually, attendance in activities is considered as part of the behavioral engagement. Also, participation, of course, in class activities or participation in extracurricular activities. All these are considered under the dimension of the behavioral engagement. While emotional engagement, from the name, feeling of, if someone goes to the university or to the medical school feeling happy, feeling that they are really want to go there, they are feeling the value, that they're proud of their college, they are attached with their peers, they are attached with their teachers. And these are all manifestations or indicators of the emotional engagement. Now, another dimension that is probably not addressed still, it's addressed very superficially, if not at all, in the medical education, which is agentic engagement. And here, this is where actually it moves from the role of the student as receiver of education to actual contributor or at least a partner. For example, peer tutoring, where the students can teach other students. So they are not only learning, but they are teaching others. So they are partners in the education. Or maybe volunteering in a community activity by teaching for example, the community, or giving lectures, or providing maybe some clinics to participating in some activities and so on. Or actually being in the governance of the university or the medical school. They are represented in the curriculum committee or assessment committee or college council or university council. All these are under the dimension of the agentic engagement. And finally, the sociocultural dimension, where actually the students are engaged in social interactions with others or gaining new perspectives and identity in dealing with other students or maybe faculty. This is the social engagement. And a culture, of course, predicting what people from other cultures can do and then start to behave according to this prediction. Or accepting to learn from other people with different backgrounds, different cultures, different languages, and so on. So this is considered under sociocultural engagement. And again, this is one of the areas that are still in infancy in medical education. And I'm going probably through some of the aspects that we have done in relation to that. So the second issue is, how do we measure student engagement? And because of its very wide nature, it's very difficult also to capture the construct by using only one measure. For example, using self-reported surveys or direct observation or real-time measures with the computer, or using interviews. All these are measures that are used for student engagement. And honestly, none of them will be able to capture the construct because it's very wide. So the best way is probably to combine different methods and try to address the wide nature of this construct. We have published last year also a review for measuring student engagement in health professions education, tried to capture the methods that are currently existing in the medical education, build on that from what has been published in higher education. And we have published this review in BMC last year. And also we developed an instrument for measuring student engagement in problem-based learning tutorials. So we are trying to capture the construct and trying to find ways to make it more clear in the medical education field. And only recently this year, we also developed a tool for measuring social cultural engagement of health professionals education students. So these all we have been trying, our group, trying to find ways to delineate this construct, which is extremely important, but still not really well addressed in the literature. Now, the other dimension or the other sphere of engagement of students is their engagement as partners in education rather than receivers. And again, we have developed this framework, even though it is still not published actually. So we looked at the 4 dimensions: the provision of education, the scholarly research, the governance and the quality assurance, and the community. And at different dimensions of the engagement. But more important, or actually equally important, is how do we involve our students as partners? Maybe sometimes, okay, you distribute a survey to the students, you get their feedback, and that's it. And you say, okay, you know, we are including our students, engaging them as partners. But this is only the basic part. This is a very basic. But you can involve them deeper in actual distribution, in actual analysis of the data, in actual decision making after the participation and so on, or being partners in the design process, in what needs to be done. And again, after analyzing the data, they can take the lead in making decisions of the changes and all. Of course, this is very ambitious, the control, where some activities actually can be run totally by the students without any sort of control by the faculty. Maybe the faculty can observe, but it is mainly done. For example, some of the programs in peer-assisted learning programs, they are run mainly by students, and there is no intervention by the faculty members. So provision of education like peer tutoring, peer assessment, student governance, curriculum co-design. So some of the courses, and there is actually more than one attempt has been published so far, where students can actually be involved in designing a curriculum along with the faculty. So it's not only now teaching of students, but teaching with students or by students, so that students become partners in the education process. In research, of course, they can do research either on their own or joint research with the faculty members, not the mandatory research that is done in the curriculum, because this is part of what needs to be done. But what we are talking about engagement in research as partners is that students, they help in designing research that is done by both faculty and the students, and the publications come under both names. And the third part is the student engagement in community activities. It can be community service, electives, or outreach activities, teaching the community, volunteering in health clinics. So these are just a few examples of how students can be engaged in community activities. What is the benefit from this to the students? Students will be motivated for more engagement because they feel the outcome of what they are doing, and they feel the importance of being actually not only just dictated and given the information, but they are actually part of the process. It helps in improving the student-faculty relationships, and that will have a strong impact on more engagement of the students. Also, the self-confidence in the improved self-confidence in academics, when the students feel that they are listened to, and the medical school is giving them importance, then they will have more confidence in what the college is doing and what their professors are doing. They will be more belong to the institution, because they will feel also that this place is valuing them, so that they will feel proud that they belong to this place, and then they will do more, and their input into the program will become more. And not only that, but also metacognitive skills. So they will have the ability to take decisions and reason the process and analyze the different components and make a decision accordingly. So, but there are challenges, of course. A partnership is not an easy issue. Students lack the expertise in this area, so this has to be taken into consideration. And also the faculty should also look at this as part of the establishing the relation. Power relations is still student and the professor. And then somehow they need to sit together and reach to a stage in the middle where, okay, you are the professor, okay, in this area I listen to you, and but in some areas I think we need to sit together and make a decision that is based on both our end. Voice fatigue, students sometimes feel, okay, you know, it's like ceremonial. We sit, think that there are partners, but then everything is done by the professors, and we are just there like something for ceremony, you know, to say that we are making a partnership. But actually, students, they understand. If they feel that they are real partners, then they will become more and more involved. Of course, faculty reluctance to consider authority because most probably of the faculty, including many of us, they think, oh, you know, we are the faculty, you know, we cannot like treat the students as equal partners. We are the authority. Then we should stay on our position. But this, I think, when once included in partnership, all these relationships should be looked at in a different way. Time constraints, because it requires a lot of time from both actually faculty and the students. And the resistance to change. It's a paradigm shift. It's something different that we are not used to. We used that the professor and the student give a lecture and they listen, give a lab and so on. We are assessing them, that they follow what we are doing. How to promote the last part, how to promote engagement of students in medical education. There are four main arms. First is to establish psychological safety, and I'm going to go through what it means exactly. And then promoting a culture of community and using active learning, and then using technology-enhanced learning. In promoting cultural safety or psychological safety is a process where the student, or anyone actually, will feel safe, that they can do mistakes, they can critique the professors, they can critique the medical school. They can, of course, within boundaries, if the constructive and so on, they can make mistakes and still it is acceptable, even it is valued by the professors. This is very important. If the students feel the psychological safety, then they will learn better, they will develop partnership better, their input into the program will become stronger. Then the other part of the medical school, which is the most important, probably the student, the end users. If they don't feel the psychological safety, then their input into the program, their feeling about the medical school will be extremely affected. The second is promoting a culture of community, where students, they need to feel that they are part of this community, not as aliens. Do not that someone come right from the beginning, from the first day of the medical school, make an orientation program, get senior peers and sit with them and they should explain to them the process, put them into communities along with the other students or committees or something like that. Start the transition from the high school to the medical school needs to be very smooth, and they feel that they are part of this community, not like people who are coming, foreigners, and this is very important for their engagement. The third is the use of active learning methods, and then the fourth is the technology enhancement. So active learning, like what we all know, team-based learning, problem-based learning, case-based learning, flipped classroom, interprofessional education, and reflective practice. All these, I think, we can talk about it for many hours, but I think because of the time limit, I'm going to be very focused and very short. Then the use of technology, that this is all based in the on publications and on the literature. Virtual patient learning, where if you use simulations, students will become more engaged in their learning, rather than using paper-based cases or computer-based cases. The use of microblogs, that will help the students to also interact across the cases that are there or with their learning materials. Of course, use of social media, maybe students are much better than us in doing that. Adaptive tutorials are designed platform that is interactive with the students, and they will help also to give feedback to them. So all these, I think, help the students to get engaged. The use of digital games, many literature is talking about that. A lot of emerging games are coming, and the gamification in education is a very strong theme that is coming with all the development of artificial intelligence and all that. It is spreading very strongly. The use of three-dimensional models, for example, in anatomy, it has been very useful for engaging the students, rather than just using the two-dimensional paper-based or things like that. Use of virtual reality, 360 videos, or mixed reality. All these are learning dashboards again, and the audience response system, the use of clickers, where you can present something and then you take the feedback from the students immediately, and then you adjust your lecture or your class according to the feedback that is received from the students, and then very engaging, and it can be actually done in with the little cost probably relatively. So that's it. I think thank you for listening, and again I would like to thank Professor Ali Batarfi and all the organizing committee, our colleagues. It is always a pleasure to be together, and I will leave my email. I think it is there in the with the committee. So if you have any questions or any interactions, then I'll be happy to answer. Thank you. Assalamu alaikum.
Thank you, Prof. Salah, for this comprehensive, interesting talk. Really, we enjoyed it. Thank you very much. Now we'll open the floor for questions and comments. We have 10 minutes for discussion. The questions are from either from online or. So I may start with a question to Professor Muhyiddin Majdoub about what he said, that we need more than competent doctors. I think this is, ambitious plan. So, Prof. Muhyiddin, are you with us? What do you mean by we need more than competent doctors? شكله مش موجود. طيب. Okay. Prof. Muhyiddin, with us? Okay. You can start because share topic with you also, Prof. Ali. You can start. Mike.
Again, I think when Professor said Muhyiddin competent, he wants to focus on moving from competency-based to trust-based. But competent doctor is enough, of course. Competent is competent. Yeah. Maybe just during his talk, but I think what he means that we have to move and encourage ABAs, and especially for postgraduate, to have a doctor entrusted. يعني باختصار نثق في الطبيب. وهو الكومبتنسي تعرف what is competent. The definition of competent doctors معناها انه passing the threshold, practicing unsupervised. If the doctor practice his tasks unsupervised بدون إشراف, that's a competent doctor.
For Professor.
السلام عليكم.
Welcome, Prof.
Okay, thank you very much. Actually, thank you very much for giving the opportunity. And I'm really impressed about the quality of the conference and the high-level presentations from all speakers. Yeah, just to answer this, what do we mean by that competent? When I said competent doctor is not enough, this means that despite really that the competencies, if you look to patient safety and medical errors, that you will find despite really our competency-based education and the investment on competency-based education, still the medical errors are really high. And now, for example, in the US, medical error is the third cause, or is now become second cause of death, which is really related to medical error. And mainly these errors are really diagnostic errors. So this means that it relates to the clinical reasoning, and it is related to the competencies of doctors. So this means that really we have to go beyond competencies. And also research in clinical reasoning informing us that really doctors can make a mistake due to a lot of biases, which is out maybe the control of doctors. And they divide this, as I have mentioned, these biases into three. That is biases or factors related to doctors, factors related to patients himself, and then factors related to the health system. So we have really to think globally by including all these factors and to have actually, for example, for enhancing clinical reasoning on our students, that students have to be exposed to the clinical early and to have to be exposed to a variety of cases so that they develop their own pattern recognition or system one, because 90% of the cases, the doctors use system one, which is really quick, effortless, and liable to errors, because this is really out maybe sometime without thinking, just people, doctors compare what the patient said and then stick to one diagnosis and then might not change. So these are all, from research and evidence that we found that really we have to go beyond competencies. And as Dr. Ali just mentioned, that really also we need to go to the, even on assessment, that is the level of trust or entrustment. It's also one of the really key issues that we have to move one step really beyond competencies. And I hope I answered the question. Thank you very much.
Yes, thank you, Prof. Muhi. Another question for you, Prof. Muhi. We
Okay.
are now about patient-centered education. Now, do you think that the introduction or the insertion of this part of the way of education, which is patient-centered, needs broad curricular reform or just some addition? So shall we change the name to be patient-based curriculum, or just enough to add it as part of the curriculum without broad spectrum change? Because I think now most of the medical schools reflecting what we have in the practice. In the practice, most of the hospitals now adopting patient-centered care. Some of them, they call it plain tree system. So shall we change the name of our curriculum in order to be patient-friendly or patient-centered, or just we have to insert this part in our curriculum without, broader changes and we'll concentrate mainly in the clinical years to be included in?
Oh, yeah, actually, this is a very important question. Thank you so much. And I think really have mentioned it very correct. I think really this is what we advocate now, that we have to move even to change the focus, because also the focus of the curriculum really will tell what really content of the curriculum should be. For example, if we call it patient and population, I think it's not only patient, but also the population that we have to consider the preventive aspects and, to do something before patients come to the hospital. This is really very important as well. And fortunately now, most of medical schools are some way or another are implementing component of patient-centered curriculum. But we need to reorganization of the curriculum to make it really more patient-centered. For example, one of the this is really one to move to patient outcomes rather than doctor's outcome. And the patient outcome are really very simple. For example, what patients want from the doctor. Patients, they want accurate diagnosis, they want appropriate management, and they want patient satisfaction. Actually, this is really the three outcomes that we have to, from the beginning, work on our students to promote accurate diagnostic accuracy, management, and also the other aspects of patient satisfaction or patient experience, now it's called. And for example, for diagnostic accuracies, this is really implementing EPAs, which will help implementing proper clinical reasoning, early exposure in the curriculum. This is also adjustment we have to meet. Involving partnership with the health system also is very important, so that we have to have shared goals with the health system. Now the health systems, they have their own goal, and we as medical educators have, so that really we have to have a shared goal towards the patient and make it really the end. And also we should work on other aspects, which is the population, that is really the community health, the public health, population health. This is also important. Social accountability is very important to be incorporated. So this really just adjustment and reorganization of the curriculum and moving really to, and also it's really a very catchy name that for any curriculum, we need to be patient and population centered. As really our colleagues in health systems, that they already moved to patient-centered practice, and now we have to move as well to patient and population-centered medical education. Thank you.
Thank you, Prof. Muhi. Just a reminder for colleagues in the Zoom, just if you want to ask, please raise your hand. The other point for the speakers, please open the camera when you talk. And the last question for Prof. Sumaya, regarding the interesting talk about the IPE. Do you agree that the role of the IPE could be more applicable in the clinical years when the team goes to the hospital all together, doctors, nurses, pharmacists, all making around together and sharing the experience, working as a team? The role is more, can be expressed more in the clinical years. And this is, I think, applicable from today. If we are willing, we don't need facilities or support, or when we decide that we should work as a team, we should start from tomorrow working. When we do our round, we should share sharing is caring, and we should work together with the nurses, with the, with the principles that you mentioned in your talk. This is my first question. And do you think that this will be cost effective even if applied in the, on the college level, in the undergraduate level in the first years, when we study medicine, say anatomy, the medical student with the pharmacist, with the nurses will be cost effective approach? And do we have any real world experience in this regard in the Arab countries that we can get some experience how they applied it? Thank you.
Okay, thank you. First, I'd like to thank you for inviting me to this conference, and I'd like to thank Dr. Ali Batarfi, and I hope you a successful conference, inshallah. Regarding this question, as I said in my presentation, this is interprofessional education, and I'm not talking now about the practice. The interprofessional education prepares or develops the team for the interprofessional practice. So it should start from the undergraduate year, and if it is very early, it is better. So in the undergraduate years, for example, year 1 or year 2, you can start with the roles and responsibilities of the different profession, for example. But when you conduct some session like this, you have to bring students from different professions, from pharmacy, from nursing, whatever, to sit together and discuss together these roles, so they will be acquainted to work together and educated together, and this will be reflected later on their practice. Of course, there will be more opportunities for them when they are in the clinical years, when they study in the hospital, when they study in the field, but to see the other profession. But you have to start it from the very early, even if it is on a very narrow scale, like a lecture with discussion or e-learning according to the facilities you have. So sometimes it is not cost much if you started with like a seminar or e-learning or something, but this will help the students to let them engage with the team from other professions, and this will help them later during the practice. Yes, again, is a second question?
الفلسفة الحديثة في كل شيء في الطب والبراكتس.
Can you raise the voice? I can't hear you.
Do you hear me, Professor Sumaya?
Yes, yes.
Yeah. What I want to say is that the philosophy for early, like in medicine, when you say early detection of hypertension, early detection of cancer. So the same thing in education. Whenever they came to early clinical contact, as I said in my lecture, from year one, you introduce students to research. So the same thing as Professor Sumaya said, we have to start not in the clinical years. We have to start from day one, from year one. But this is as a philosophy. Whenever you have the chance to make students engaged in something early, it's better. Thank you.
Yeah, thank you very much. And as I said before, there are many countries in the Eastern Mediterranean started this experience, and mainly Qatar did a very good models for this, and also they developed the interprofessional network. So it has a lot of activities. If we can also share in this, it will be great. They have many people from different countries, and I advise you also to have some people from Yemen to share in this network.
Thank you. دكتور علي، فقط أريد أتحدث معك بصوت مرفوع أنه حان الوقت لنا نحن هنا في اليمن أن نفكر خارج الصندوق. نحن في الجامعة الألمانية بدينا من اليوم الأول. من اليوم الأول سمينا، أعطينا الطلبة أوفركوت وكتبنا عليهم دكتور، أصحاب الطب البشري. وطبعا أنا قرأت من قبل من أبحاث أنه from the first day we should say you are doctor. من سنة أولى كانت الفيزياء تدرس بطريقة صعبة جدا، فأخذنا الطلاب، تكلمت مع الدكتور قلت له ابدأوا التطبيق من الفيزياء، فدخلوا إلى المستشفى ليتعلموا الإي سي جي، كيف يتحول الكهرباء، يتحول إلى الرنين المغناطيسي، إلى الأشعة المقطعية. دخلوا المستشفى في سنة أولى بالفيزياء، فخلق نوع من الأريحية لدى الطلاب، بأنه نحن دخلنا المستشفى وبدينا نطبق حتى بالفيزياء قبل ما ندخل للكلينيكال ساين. نفس الحكاية في طب الأسنان، بدأنا ندخلهم من البداية من سنة أولى إلى المستشفيات والعيادات. أعتقد أنه آن الوقت لنا نحن في عدن أو في اليمن أن نغير من طريقة تدريسنا، نغير من طريقة تفكيرنا، أنه محاضرة محاضرة محاضرة. لازم أن تتغير هذه الطريقة وتتغير إن شاء الله من هنا بإذن الله تعالى.
شكرا دكتور عبد الفتاح. دكتور صالح بشعيوت. اضغط على الزر الآخر.
Dr. Sumaya, a third domain of IBE that you said interprofessional communication. Interprofessional communication, one of the most important communication is the language. And most of the conferences and also medical colleges are always from the early or the first year starting with the Arabic English language. Many of the students, or sometimes even in the conferences, many doctor does not know many terms, difficult terms. Why not we start to introduce some of the Arab terms within the team framework discussion sometimes when there is discussion as an official issue to introduce Arabic terms in the frame of the teamwork discussion and this يعني IBE.
I think doctor, they will speak in Arabic if they are from Arab countries, because they are all of them are from Arab countries, or from Yemen, for example, from different professions. They will speak in Arabic, no problem. But really, we prepare our student to be able to work on the global level also. So that's why we use this English. But definitely they will speak in Arabic during the team, their team with the nurses or with other profession. No problem for this. But they should also be trained to speak in English, because as you know now, many of the students go abroad and they work outside, and they should know the English language to communicate with the patients in different countries. Thank you for this very important question.
Yeah. Thank you, Prof.
Thank you.
The last question for Professor Abdullah Al-Hinshi.
First of all, thank you very much for distinguished speakers and very important lectures. My questions about interprofessional educations. This is a very important issue, but what happened is there is rigid about the indicators, rigid mind. Also, many educators are not convinced. ممكن نقول إنهم كل واحد متمترس في his professions. فما فيش نوع من الانتجريشنز. فرجاء أن يكون في هناك culture، أن يتم نشر هذه الثقافة بين كل الإديكيتورز حتى نستطيع أن نعمل implementation to this issue, especially in the domains mentioned. على الأقل ممكن Arab University تكون باينرز في هذا المجال وتتبنى موضوع الدومينز في الإيثكس في كثير من القضايا. فأرجو أن يكون هذا المجال هو يأخذ بعين الاعتبار من توصيات المؤتمر. أنا بتكلم في بعض الأشياء بالعربي لأن احنا we are Arabic و many are speaking in this. Another issue what he mentions, Dr. Ali, about the challenges. There is doubling of knowledge. What is from his opinions practical view to implement the important skills in the curriculums. يعني في كثير من القضايا جديدة. ف what is the practical advice we can say to implement these new advances in the curriculum currently? To Dr. Ali. Thank you very much.
شكرا بروفيسور عبد الله. نحن لن نخترع العجله من جديد. معلش في معنا ناس على الزوم نن عرب سبيكر، فحتكون بالانجليزي مشان يفهموني، ولا المفروض اتكلم بالعربي يعني. So we're not going to invent the wheel from again.
السلام عليكم ورحمة الله وبركاته.
This challenge ايمان بصديق هذا ليش الراعي يا ايمان؟
لك راعي انت اعطيني فرصة اتكلم اسكت.
ليش الراعي؟ طيب انا دائما لما اتكلم يقول لك الراعي يا بطرفي ما انا قلت لك الراعي يا ايمان.
Okay, I have some comments.
السؤال بتاع عبد الله الاجابه عليه هو ان احنا في ناس يكونوا ميديكال اديوكيتر هم كوريكولم ديزاين، فلما يعملوا الكوريكولم ينتبهوا الى اضافه المهارات والمعارف الجديده. ولكن انا نبهت في محاضرتي انه اذا كان الناس اللي بتتلاعب بالكوريكولم ليسوا اكسبرت حيصير كوريكولايتس، حيصير كوريكولوباثي، حيصير كوريكولوما. فلازم ننتبه لهذه المساله، بانه من سيعمل على اضافه نولج او سكيلز معينه يجب ان تكون وفق ستاندرد وسيكونشال، والبري ريكويست تجي قبل الريكويست، بحيث انه الامور gradually we can build it، مو فجأة واحدة، وهي مش صعبة. ونحن عنوان يا جماعة، بس فكروا في عنوان المؤتمر Reform of Medical Education، تطوير وإصلاح التعليم. نحن نريد أن نعمل هذا الشيء. وأنا أطمن الدكتور عبد الله أن نحن في جامعة العرب فعلا متجهين نحو الانتربروفيشنال اديوكيشن إن شاء الله، وقد يساعدنا احنا أنه في تخصصات عندنا 5، عندنا طب بشري، عندنا صيدلة، مختبرات، علاج طبيعي، وسمع ونطق. ويمكن تخصص سمع النطق هو الوحيد في الجمهورية لحد الآن. في اليمن عامة ما يوجد. سمعت انه في صنعاء يفتحوا هذه السنة، مش عارف فتحوا او لا. فعموما what I want to say is that بإذن الله those who are interested in curriculum design and in curriculum development they can help their schools by reviewing any updated knowledge skills and add it to their curriculum. ونحن هدفنا من هذا المؤتمر هو نشر يعني ثقافة الجودة وتطوير المناهج. وطبعا الكوريكولم is dynamic process، ما فيش كوريكولم static، و no one size fits for all. ما في كوريكولم حيعم على كل الكليات حيكون هو النموذجي. it is a contextual يعني dependent. Thank you.
شكرا دكتور علي. Any comment from Madam faculty?
Yes, I have a comment.
Yes.
First, thank you very much for sharing with us this international scientific conference. It is a great pleasure for us to participate with you. All the topics which are presented were really very informative, but it's not something new when we talk about interprofessional education or student engagement. This has been done in the late 70s when we were medical students. We were student assistants in the basic sciences, and students were also engaged, and are still also engaged until now. But this is, I should say, this is a remodeling of a new framework for new terminologies. It has been in a dynamic process, but currently it has been becoming static. So we need to make some novel, we can talk of it as novel biomarkers for medical education. I think that this process should continue, and we should also say that we might ask for some changes, but we don't say that because people are changing, we should change. We should tailor each to our possible resources, human and medical resources. We have overcrowding of students. We cannot perform all what you have said in what we are currently suffering from, but we try to make points. We have student engagement. We have interprofessional, but not up to the level of standard that we can say that we are doing it continuously. And thank you very much for that.
The last question, I think, for Dr. Nawal. I think time is over more. Yes, Dr. Nawal.
My question to Dr. Sumaya about the challenges in IPE. The mainly, I think that there is a lack of the central planning and supportive administration. It is considered the first challenge. And now how we overcome this challenge or the obstacles?
boy. Open the mic, please.
Thank you for your question, Doctor. First, I would like to comment on the doctor from Aden who said that this is old theories and right. The interprofessional education, for example, started many years ago, but it is still lacking in the Eastern Mediterranean region. That's why I showed you the situation in the Eastern Mediterranean region and the publication in this area, which is recent. So we need to encourage these important approaches. For you, Doctor, you talk about the interprofessional education and how to implement in our countries. And I'm telling you that this is can be done on in phases. You start at first because you have to have leadership support at first. If your leadership is convinced with implementing interprofessional education, you can proceed. If not, you can't proceed because you will need to have a committee at first. This committee will be included people from different professions. If you are a faculty of medicine, so you have to have someone from the faculty of pharmacy, from the faculty of nursing to select with each other the competency framework and put together the intended learning outcomes and decide about the content, because this content should be matching all the profession. And as I said before, the interprofessional education is not about the speciality of each profession. It is not something scientific for each profession. It is something related mainly to the teamwork and the collaboration. And as you saw, the competences related to the ethics, related to the teamwork, related to the collaboration, the roles and responsibilities of each team, of each profession. So it is important to start with convincing your leadership to implement the interprofessional education. And as I said before, you can do it on stages. As you see, some colleges are just doing a seminar once in the curriculum. They just bring students from different professions and they sit together and they have a seminar. They discuss something, and every profession has its role in this discussion. So they have this interaction. So this is something. Another one, you do a workshop, or you ask the student from different profession to go to a specific place to do the challenge model, as I said before, so you can do it on different scales. So this is the first thing, please do by starting convincing your leadership to implement the interprofessional education. Thank you.
Okay, thank you for all the speakers, also for the audience. Yes.
أنا هقول كلام قد لا يعجب الآخرين، خاصة اللي تدربوا في الويسترن كانتريز. كله كلامنا عن USA وUK وكندا واستراليا. اللي قالته كلام إمام بصديق كلام صحيح. أنا أؤمن بأنه كوبا مدرسة طبية منفردة، ولذلك من أن قامت كلية الطب عدن 75 من ذيك الأيام دخلوا أشياء في الحقيقة بروبلم بيزد وامسك كل اللي نتكلم أشياء كثيرة نتكلم عليها الآن حديثا كانت موجودة في كلية الطب من عام 1975. لكن سياسة العبدور هتتكلم عن كوبا حيقول لك كوبا اشتراكية، عسكرة، ميليشيا إلى آخره. أنا قناعتي الشخصية بأن كوبا تمثل مدرسة طبية يونيك في العالم كله.
شكرا دكتور علي. I think now we are coming to the end of this session. We'll meet again after 10 minutes break, inshallah. Thank you very much.
Thank you. Thank you very much.
15 minutes, okay.
Okay, thanks.
Thank you.